from such a large group. I just wanted to make a few introductory remarks and then introduce our first speaker. It was almost exactly a year ago that the NGO Committee on Mental Health organized a presentation on trauma-informed mental health care. Dr. Irit Feltzen, the co-convener of the Trauma Working Group, facilitated what was a very moving in-person discussion in a large room filled with people near the United Nations. That was the last group meeting that I attended in person. 1 month later, the world began to recognize an impending global pandemic that has now shut down all of our in-person gatherings and left only frontline health workers and other essential workers out there sacrificing to care for others. The mental health impact of COVID-19 pandemic is a crisis second only to the devastating loss of life brought on by this virus. In the United States, the medical and economic consequences of the pandemic have been felt disproportionately in communities of color and communities with inadequate access to health care. Globally, excuse me for 1 second, I have a tickle in my throat that is getting in the way. Globally, excuse me, I'm sorry. Give me 1 second. So I wanted to also talk a little bit about the fact that post-traumatic stress disorder is by definition a disorder triggered by a past terrifying event. Just this past month, a study published by an Australian university demonstrated that 13% of individuals studied in 5 Western countries met the diagnostic criteria for PTSD based upon traumatic stress related to future events, such as worry about oneself or a family member contracting COVID-19, or having direct contact with the virus, or having indirect contact, such as via the news and government lockdown. All of these considered non-threatening life events. Those of us working in the area of complex post-traumatic stress disorder know well that social and relational stresses can be as devastating as a life-threatening event, and that relational trauma during childhood increases the risk of later development of PTSD. The professional organization that I represent on the NGO Committee on Mental Health Executive Committee, which is co-sponsoring this event, the International Society for the Study of Trauma and Dissociation, encourages ongoing recognition of the significant and lasting mental health impacts of violence, poverty, disasters, denial of human rights, lack of access to nutrition and education, forced migration, and other disruptive social conditions. These kinds of circumstances produce urgent needs for healthcare personnel to be thoroughly trained in trauma-informed practices. Today, we are fortunate. Well, I want to say one other thing that I don't want to forget. I mean, a little silver lining to this being an online presentation is, as I mentioned before, the vast number of individuals from around the world. And I am thankful to everyone who is participating in this outside of their normal waking hours. And I also wanted to particularly thank the NGO Committee on Mental Health interns, in particular Fordham University student Shania Osborne, without whom this would never have happened. So today, we're fortunate to have 3 presenters who will discuss with us not just the traumatic consequences of the pandemic, but also will explore the role of resilience and post-traumatic growth in both coping and healing. I'll just mention, so to keep you all here until the very end, that our final speaker will offer us something called the Scope Safety Aid, now being used with frontline healthcare workers to stabilize the physiological stress response and help build resilience to get through crisis. As we mentioned at the beginning, I'm going to ask people to put your questions into the chat box. If it feels organizationally possible, we'll do a few questions after each speaker. We'll try to limit that so we don't run into the time of future speakers. And then I'm hoping that we have a good, 20 minutes to half an hour for discussion afterwards. If all the speakers are able to stay, that would be great. I know one of our speakers is already in his evening time, so we'll see how that works out. So let me introduce to you the first speaker, Abel Learwellie, who is Executive Director of Camp for Peace Liberia, and I'll add, a valued member of ISSTD. Abel brings to us a broad understanding of violent conflict, marginalization, and intergenerational effects of complex trauma. He's dedicated, innovative, and a determined peace builder, educator, and social scientist. He's contributed to the body of knowledge and practice for conflict resolution and trauma mastery. His contributions build local capacity and sustainability that are contextually relevant as well as adaptable for international use. Having experienced and survived 14 years of civil war, Ebola, and now COVID-19 in his country, Abel brings the authenticity of experience in conflict and trauma mastery to inform his avocational passion and ongoing professional development in his beloved service, Liberia, and the world at large. So I bring to you, Abel. I'm going to put my screen on speaker view, and hopefully, is he here?
Yes, I'm here.
Okay, here you are.
Thank you so much, Karen. And
I just want to warn you that after 20 minutes or so, I will interrupt you.
Oh, no problem.
All right.
Thank you so much for providing me the opportunity tonight to share with you on this wonderful platform, talking about coping with trauma and building resilience. As I'm going to bring to bed my personal experience here in Liberia as it relates to trauma and how we are managing the daily reality of coping. For us here, we most often consider some of these are very normal because a substantial part of our life have been with disasters, watching disasters, witnessing disasters, living with it on a daily basis. So sometimes we cannot consider it as a very normal situation. I've traveled around the world and I've seen life in different forms. And sometimes it's just uncomparable to see who we are and the kind of a resilience that we build as a country and individuals on a daily basis that have been very marvelous. And I tend to sometimes recognize our own strength and our own resilient spirit that is making us to live. As you regularly say in the introduction, we grew up in a very difficult terrain here, and then we were faced with a very deadly civil war, one of the deadliest civil wars ever in Africa, where we had lost a life of 250,000 people in a very small nation of 3.5 million persons. Over 250,000 people. Maybe that's just what on record of the war between 1990 and 2014. But there were just more than that. A lot of people fled their home unarmed for 14 consecutive years. So we survived all of this. For matter of fact, some of us became a direct victim. We're being kind of incarcerated, we were being intimidated, and we were forced to become child soldiers for that battle, something that we never ever thought of doing in our lives. So we witnessed direct massacre of people, murder of people. We witnessed women and children being raped, being killed. And we went through all of the rap that anybody could think of. So, looking at trauma and still living the way we live and we happy with what we do, sometimes I turn to say congratulations to us, to me. Right after the Civil War, immediately 10 years after the Civil War in 2004, and then we were trying to kind of rebuild our life, to put our life together. And then we were again struck with another disaster, a very great calamity, which was the Ebola. The Ebola outbreak was a kind of a surprise to all of us in 2014. And it lasted for nearly 1 year, but it took away a lot of lives. Approximately over 7,000 people died in the Mana River Basin just for Ebola. And they was considered as an invisible enemy. I try to compare the crisis of Ebola with that of the Civil War, where maybe when you see your enemy, you are able to take a better positions and maybe try to escape or face the reality of time. But Ebola was like a very blind weapons that come from nowhere. For Ebola crisis. So it was a kind of a disaster that one could ever think whether they could survive because of what was actually happening. And then today we are again faced with COVID-19. 6 years after Ebola, trying to again put our life together, and then we were again hit by COVID-19. And the COVID-19 have had a lot of effect on us. It have affected our culture, it have affected our tradition, and it have devastated our economy. So now if you see what is happening from 1990, so to speak, to 2020, that's about 20 years of uninterrupted 20 years of uninterrupted life without normalcy. 20 years. That's a lot. No one from this country who can tell me that they have ever enjoyed any normal life since 1990 up to present time. We're about to enter 21 years. So children born during 1990, imagine their age right now, they have turned 21 years without understanding anything that is normal life. Besides just measuring all of these events like the Civil War, like the Ebola outbreak, and then now we're talking about COVID outbreak. The daily realities of our communities just it's so devastated. We live in a society where there's no electricity, where there's no pipeline water, where there's no better educational opportunities, where there's no medical facilities provided. And we always say we live one day at a time. And many people say we are only living by the grace of God. You know, so imagine those kinds of situations. And a typical Liberian family is living less than $1 a day. Sometimes, so many times I tell my son, you have to live by what you have and accept condition as it is. With me, maybe my experience from outside, traveling all over the world, going to Canada, the United States, and other countries that are more variable, and seeing life in those countries and comparing that with what we live in Liberia, I feel that we are devastated. But you will not believe when you enter this country, you still see laughter on the face of people. You see happiness and joy. Then you wonder, what is wrong? Are they living on different parts of the planet Earth? Many people have said that to us. If you ask a typical Liberian, what news? How are you doing today? They say, I'm good. There's nothing wrong with it. I'm better. Somebody have not eaten maybe for 2 days and they are telling you, I'm okay. You do not have any hope for medical. You do not have any hope of turning your situation around, and you still say you are okay. I think that's a kind of a beginning of the resilience that we build. Building resilience has become a normal part of our life. And we have been very hopeful, very, very hopeful that things will always change for the better. For the fact that we went through 14 years of civil war, I personally feel that one day life could become better. So during the Civil War, that's part of witnessing all of these horrors, all of these disasters. I had the strongest belief that the Civil War could come to an end. And surely the Civil War came to an end in 2014. And then coming back to Ebola, when Ebola happened, it kind of took us back to the Civil War. It kind of reflected our memory right back to the Civil War. But again, Liberians said, we will live with this. We have to live through it. I used to be at home and talking with my kids, and I told them that this will surely come to an end. For the fact that we went through 14 years of devastating civil war, we will surely go through this. And surely, Ebola was also done with. We went through and it was done with, but we are always happy. We are happy because we are still alive. If you look around you, you have had several persons dying, several people were being murdered in the crisis, and how lucky you are, how lucky I am to still be alive, to interact with people from different backgrounds, people like you. Many friends, like my friend Anne Becky in Canada, Lois Coco, and several friends that I've had in my life. And I've said I'm one of the luckiest person, and I need to take the joy. I need to take the joy to other people. Other people need to be a testament and a testimonies of the kind of a joy and privilege that I have. That's part of all of the difficulties that we are going through. Ebola did not only affect our lives, but it also affect our culture and tradition. Because here in Liberia, one of the best ways we can kind of counsel each other. We live a kind of a communal life. So if you're telling me not to visit my brother or my sisters or my friend, I consider as an affront. If you tell me not to shake hands with people, I also see that as an affront. So there were a whole lot of issues that sparked up during the Ebola crisis. And all of those things are kind of a surface during the COVID-19. All of the practices, all of the things that happened during Ebola is exactly what we are also seeing during this COVID. But being that we are so much resilient and we've kind of grown into this and we build a kind of ability to withstand. Another thing I've said, the best way that I can cope with my traumatic war experience from the war is to kind of continue to share my stories, those horrible stories, those horrible events. So when victims meet, when we begin to share these stories together, we feel much grateful and we feel very hopeful. And that's what all along we have been doing. That the story of the Ebola crisis, we sometimes share this and it become a joy and a laughter for everyone. Because you are in your house and you see your brothers or sister coming to your door and you tell him or her and say, look, I don't need you here right now because Ebola is around. That alone set a kind of a huge trauma and a devastated relationship as well. So going through all of this, we are a resilient country, we are resilient people, and our way of living, when anything that affects one person in the community affects every other person. So if there's a death in a community, you see everyone from the surrounding neighborhood comes in to kind of help, to give the necessary support and the resources that is so desired. You have the women pouring water, you have the men bringing wood for fire, you have other people bringing food and different kinds of things. All of those things help us to kind of really face the reality of time. Because we know trauma cannot be undone. I have a lot of scars on my skin, you know, from most of the intimidations that I went through. I cannot undo this scar. But what I've done is I've learned to live with it. I've seen it as a reality, and this really happened. And it happened for good. And I should accept it. I saw that during the Civil War, some people committed what's happening around them, and even doing the we that survive and still surviving, we have a very good stories to narrate. We are always hopeful for the future. We know that COVID, for the fight we can do away with, we also do away with COVID. So it's about accepting reality at a time and making all efforts, using all necessary resources that you have to your disposal to make life better at that movement. We made it better during the time of the Civil War. We were able to find time to still do some of those things that we did during normal days. We made it better during the time of Ebola because we accepted the reality that it was a time for it and we needed to face that reality and to take all necessary measures in protecting ourselves. And today, we have also accepted the reality that COVID is real, it is here. And this is also the time of COVID. So we have to do all we can to go through this. So it's about being hopeful. It's about trusting that things will become better. It's about accepting fact that this is a new normal and we must live with it. And then once you have all of these, accepting all of these, then you will not have the ability to resist and to keep moving until the better life that we are all hoping for can come one day.
Okay. You know, I feel like we just had a little spiritual uplifting. And I don't see if anyone put any questions in. If there are any one or two questions that somebody wanted to ask before we move on, just like in 5 minutes, if anyone had a comment, please put it into the chat box so we know that you have a question. So I don't see, so I think that what we'll do, can you stay until the end of the program?
Yes, I will be around. I will stay around. Maybe it's now 7:26 p.m. here in Liberia, and I am staying in my office, but I got my colleague with me, so
Okay.
I don't feel much threatened
Okay.
with
Well,
that.
thank you.
Yeah.
Thank you very much. Okay, thank you. So I'm going to introduce the next speaker. So our next speaker is Dr. Laurel Mayer. Okay.
Oh, Karen, there is a question someone had.
Oh, okay. So I'll read the question. This is from Amie. In Liberia, do you see many people looking to pursue paths to healing their experience of the traumas, you have described? It's going too fast now. Okay. I'm sorry, now the questions are pouring in, so I lost the question. Maybe.
I have a question here.
Okay.
In Liberia, do you see many people looking to pursue paths to healing their experience of the traumas you have described?
Please, I want you to read the question.
Absolutely. So in Liberia, do you see many people looking to pursue paths to healing their experience of the traumas you have described?
Yes, absolutely. Absolutely. There are a lot of people here that have survived two major disasters, and this being the third in just 20 years' time. So that is a clear demonstration that people surviving the war, people surviving the Ebola now, living with COVID-19, they have a very strong resilience drive in moving forward with their lives. You know, to survive such major disasters 3 different times in less than 20 years, and then coupled with the daily happening of what life is, how devastating that life look here, where you live and you live like you have no other means and you still look happy and moving. Yes, a lot of people in this country have kind of embraced the challenge and stay moving on. That is a clear manifestation of the kind of resilience that they have built over the years.
Okay.
And we have one more question. Would that be okay?
Yeah, I think we have a
Okay.
minute. Yeah.
Okay, so we have one more question. Can you comment on your understanding of resilience for the development of perpetrators, or how some are enlisted into victimizing others?
That's not a quick question.
Yeah, thank you. My understanding of resilience, I think resilience is more like the ability that one's built in the face of adversaries, in the face of constraints and challenges. You know, whenever you build ability to brace constraints and challenges that I have just really talked about, it means you have some level of resilience. But there are a couple of factors, in my opinion, that just kind of contribute to that. I think the collaborations that we have with each other, the kind of a relationship that we build around one another, considering everyone to be the same family. In Liberia, there is no different persons. Everyone considers someone as either their brother, sister, nephew, or uncles. So we are kind of we are interrelated communities. So we feel whatever affects one person affects all other people, you know. So we always say to ourselves, we are not alone, and we will never get through this alone. There are many people everywhere that have kind of going through all of this kind of a thing. So with COVID-19, I think we all need to remember that COVID-19 will definitely come to an end, because there's nothing that lasts forever. Every good thing and every bad thing has an end. And we should also be cognizant of the fact that we cannot just do anything about this. All we can do, maybe outside of our personal thinking, is to live by those basic preventive measures and care that it gave us. But that's not just all to it. There's a whole range that come along with it. For us, we have a serious economic crisis, a serious economic crisis that is so much devastated. Sometimes I tell people that the consequences of COVID-19 is even more than the virus itself, because people are dying from hunger. People are dying from other sicknesses and then just COVID. But COVID is the factors of all of this happening. So the reality have to be accepted that we have time. Time comes and time goes.
Okay.
So whenever it is time for you to face whatever challenge or difficulty you have in your life, the first thing to do to go around that is to accept the fact that it is real, after accepting that fact, you should also know that this will come to an end and you still have a better life to live even after this.
So I'm going to end the questions here. I want to quote one thing that you said to segue into the next speaker. So early in your talk, you said building resilience is a normal part of our lives. And that's something we could talk for hours about that. The next speaker, I want to introduce the next speaker, who is Dr. Laurel Mayer, professor of psychiatry at Columbia University Irving Medical Center. She's the director of the New York Presbyterian House Staff Mental Health Service in the Columbia campus, supporting residents and fellows at Columbia for the better part of 15 years. She's particularly interested in the relationship between burnout and depression, and she has been involved with something called CopeColumbia since its inception in March 2020, providing peer support services to the healthcare workers and staff of the CUIMC community during the COVID-19 pandemic. And I'm very eager to hear. Now we're going to transition to talking about studying individuals in the United States, where I think we have a very different experience of resilience, whether we have it or we don't is a question. But to present your research on, frontline healthcare workers right now in this pandemic. So
thank you. Let me thank you so much for that introduction. I do feel that I knew that the first speaker was going to be so powerful, and I hope we can pivot a little bit to a more academic talk, but I want to say that I really appreciate the discussion, and I'm a rather informal speaker actually, and I really hope that even though I have slides and I'm going to talk about research studies and data, that's really all grist for our very hopefully lively and rich discussion about this topic. And I really do appreciate this opportunity. Let me see if I can get this going. Sorry, one second. Okay, can you all see that? Am I good here? Okay, so again, thank you very much. And I'm going to talk about the impact of COVID-19 on the mental health of our healthcare workers, and hopefully convince you that there are some strong signs of resilience. You know, this is an old slide already. It's from February 7th, but clearly COVID-19, as we are all acutely aware, is a global pandemic. There are over 100 million cases of infected individuals throughout the world, with unconscionable numbers of deaths. And it's going to take all of us working together to get a handle on this pandemic. And so I thought it might be nice to start with a quote from Dr. Herman: "The solidarity of a group provides the strongest protection against terror and despair, and the strongest antidote to traumatic experiences." So again, I want to thank the organizers bringing all of us together to do this, because it will take all of us together, working together, to help us build our resilience and make it through. Just a brief overview of what I'm going to talk about. I'm going to talk a little bit about physician mental health before COVID and what that context was like. I'll talk a little bit about what we've learned about the psychological sequelae from previous pandemics. A little bit, as our previous speaker alluded to, COVID-19 is not the first, even if it is actually perhaps now the worst that we've experienced. And we'll talk a little bit about what we know about the psychological sequelae of COVID, as it's now about a year into it. And I'm going to then talk about what we can do, and I'm going to describe the CopeColumbia response. That's the support services that we put together at Columbia. So let's start with the pre-COVID context. What was physician mental health like before COVID? Well, what can we anticipate about the psychological vulnerabilities in our physicians? Well, if you ask physicians, they would not acknowledge probably any vulnerability, but yet we know clearly that our physicians and our healthcare workforce are both incredibly resilient, but also at increased vulnerability to the negative sequelae of trauma. I'm going to show you a little bit about the data even before COVID of high baseline rates of burnout, of depression, of suicide. As a group, physicians and healthcare workers in general are less likely to reach out for help, so they are therefore more likely to self-diagnose or self-medicate themselves. We know that the systems that we work in are inefficient. Sometimes there is a lack of autonomy and meaning in work. Let's move a little bit to burnout. Again, this is all pre-COVID. Emotional exhaustion is high. In physicians, it's upwards of 50 to 75%. In nurses, it's been reported to be upwards of 45%. And even when we think as physicians or healthcare workers that we have it all under control, and while we might be emotionally exhausted, it doesn't impact our patient care. In fact, it impacts our patient care. The healthcare workers that have burnout are more likely to feel like they've made a medical error. Even when they might not have made an error, they worry more that they have. They are more likely to comment that they've had less of an emotional reaction to the death of their patient than someone without burnout. It even impacts patient satisfaction scores, which I'm sure a physician would never think would happen, but it increases the likelihood that patient rates hospitals poorly or might not even recommend that hospital for care. And we very much know how much our hospitals care about their good ratings now. And burnout also, healthcare workers with burnout are more likely to consider leaving their job. But burnout, as I mentioned, is not the only issue that healthcare workers were grappling with. Our physicians were also grappling with depression. These are actually our trainees. This is from the intern health study. And this shows that before internship, our interns have rates of depression that are very low. But then by the summer, by 3 months into internship, screening for depression using the PHQ-9, about 25 to 30% of interns will meet criteria for moderate depression. And those rates stay that way for the remainder of the year. It's not that it's only the same person that stays depressed for the year. People move in and out of depression, but about a quarter of interns will meet for depression during internship. This is pre-COVID. And again, why do we care? Well, we care because depressed interns were more likely to say in this study that they reevaluated or regretted their decision to become a doctor after spending so many years to get to that point, to after 1 year think about wanting to leave is problematic, especially if it's related to the depression, because non-depressed interns were more likely to comment on their strong sense of social support. And as we've been talking about, what's protective against the impact of stress and trauma is a sense of social support. And if depressed interns don't focus on that, we have to help them. And in addition to burnout, in addition to depression, physicians are at higher risk of suicide. And about 400 physicians will take their own lives each year. That is more than one a day. And for people who are so resilient, who are so accomplished, who offer so much, and we need them to take care of us, this is unacceptably high. And that was the context before COVID. Hold that in your mind for a few minutes while we move to what we can learn about the psychological sequelae from previous pandemics. First, let's talk about, and our previous speaker mentioned this, this pandemic will end. Disasters, pandemics, they have an arc, okay? Sometimes there's warning and there's a buildup and we get ready for the disaster. Sometimes we know it's a blizzard coming or an earthquake that might be coming. And then there is the impact. With COVID-19, we had very little warning. It just hit us, especially here in New York. But the first phase was a heroic phase. Everyone comes together in the face of the trauma, the stress, the illness. Everyone came together. Everyone stepped up to do what they needed to do, and usual rivalries fell away, and we felt stronger together, and we could do it. And then we managed the peak, and then the peak of the first surge subsided. But as that also subsided, then we realized that a little bit there was an increasing gap between the needs of the people and the assistance that was available, and it leads to a little bit of a feeling of abandonment. There's an increased demand on services, and we are currently solidly in this disillusionment phase, wondering when this will end, wondering what other stresses will come our way, and how are we going to be able to deal with this. The optimism that really defined the heroic phase wanes a little, and we have to think about how to hold on to it. What we also know from disasters is that the time frame for the medical and the psychological footprints are off a little bit. And as our medical cases will resolve, as our vaccines work, as we develop herd immunity, as we get more and more treatments available for COVID, the medical sequelae will improve, but the psychological sequelae will remain with us for quite some time. So it's critical to understand what to expect. Most people are resilient. For most of us, we deal with stress every day. We figure out our coping mechanisms that help get us through the experience. And then along the stress continuum, sometimes life is a little bit harder than we expected. This is certainly what we are experiencing during COVID. It is more severe for those on the front line. And so we need a little bit more support. Some of us may have these distressed reactions or engage more in risky behaviors, a little bit more drinking, a little bit more impulsivity. And for some, the stress will manifest all the way at the end of the stress continuum, and some will actually develop frank psychiatric disorders, brain disorders. Most will not, but some will, and it is critical to know and to expect that, because those illnesses require treatment, evaluation, and treatment by trained professionals. So we need to be alert and ready to take care of the range of reactions, both to support the resilience and enhance our healthcare workforce, and all the way through the end of the spectrum. So let's just take a pause here for a few seconds, and for you to think. If you're comfortable, you can put it in the chat. If you'd prefer to sort of just reflect on it yourself, what's been the most stressful aspect of COVID-19 for you? And while you think about that, I'm going to show you what you are likely, many of you have already said, but common challenges from the pandemic include the stress, the loss, the change, the amount of death, the loss of our loved ones, and, as was alluded to, changes to our mourning rituals. Whoever thought that they would attend a Zoom funeral or a Zoom Shiva, or not be able to put a hug or an arm around our grieving family or our grieving friends. The financial hardships that we are enduring and are about to endure are not uncommon in pandemics, but can have very personal impacts and can lead to lower self-esteem. We haven't just lost loved ones to death, but we are also grieving the loss of milestones, of birthdays, of graduations, of celebrations, of holidays. Those are real, and those have an impact as well. Disruptions in education, both for those in secondary school and in colleges, we are going to see for a long time what the impact of those are. And for those of us that have had our work activities disrupted, who would have thought that we could have pivoted to telehealth quite so quickly and so successfully, or pivoting to teleconferences. As you said, a year ago, this conference would have been in person, full of a room of life and vibrancy and activity and discussion. And we can get some of that on Zoom, but it's not the same, and we've had to adjust. It's impacted our relationship, it's impacted our neighborhoods and our communities. These are the common, as you all know, I don't even need to spend more than a second on this slide, common psychological responses to disasters or crises. It is normal to feel shock, frustration, fear, rage, shame, isolation, helplessness, guilt, and mistrust. If that's what we're feeling now, that's not the abnormal part. That's the normal part. And the data from our studies bear this out. This is sort of a summary slide from studies done of symptoms in response to SARS, MERS, Ebola, and distress rates are as high as 89%. Stress also from 42 to 89%. Anxiety in some studies was rated almost 100% of participants, and depressive symptoms also, and substance use increases. And we know from SARS and from previous pandemics that these sequelae are not just during the acute phase, but they last for years afterwards. So what have we learned, if anything, about the sequelae of the psychological sequelae of COVID-19 in healthcare workers? Regardless of how healthy or well-adjusted you are, the experience of stress and anxiety and other emotions may emerge. We have at the national level people thinking and saying and writing that we have a brief window of opportunity to get ahead of two pandemics, the spread of the virus today and the harm to clinician well-being tomorrow. If we fail, we will pay the price for years to come. In the race to respond to COVID-19 crisis, we must not forget, we must not neglect to care for those who care for us. And that is an interesting position for us to be in, to be the caregivers of the caregivers and figure out how to both manage our own reactions to this trauma as well as support our colleagues in this. What can we anticipate about the psychological vulnerabilities in the COVID-19 context? I don't think I need to go through this with you. I am sure you are all well aware that younger age is a risk factor. Those working on the front lines with a higher dose of trauma are more vulnerable. People with pre-existing vulnerabilities to psychiatric disorders are more vulnerable. And remember back to what I was telling you about the pre-COVID context of our healthcare workers. I want to talk also about the presence of secondary stresses, because this is what we've been dealing with in the US for the past year and ongoing. It's not just COVID-19, but it was also the George Floyd murder and the realization of the extent and the urgency with which we need to face the racial injustice, and we need to dismantle systemic racism that is pervasive through our country. We had the impact of climate change and the wildfires in California. We had the stress of our political climate. The lead up to the election was very, very stressful, and it has not gone away despite the ending of the selection of our new president. But the insurrection and the current impeachment and trial of the ex-president is an ongoing stressor. We had the hope of the vaccine, and then we had the actual rollout of the vaccine, which was not as smooth as we would have liked, and as we as a country can certainly do better. And then we have now the variants of coronavirus that we now need to deal with. All of these are stressors on top of the existing COVID-19 stressor. So how are our healthcare workers dealing with it? Well, as we would expect. These are studies from early last year, from China, from Italy, from a group at Columbia that looked at rates. These are during the acute surges, the acute phases of the coronavirus pandemic. And you can see very high rates of traumatic symptoms. This is during the acute phase. So this isn't PTSD yet. This is more acute stress disorder, but very high rates. And this is actually showing that this is a global effect. It wasn't just the US or the healthcare workers in the US. These happen to be 4 studies actually reviewed by Claire Asen, who is on this call right now and is a medical student who's working with me, still choosing to become a doctor herself, but the rates of distress throughout the world as the healthcare workers take care of the patients who have COVID-19. These are our trainees are also affected. This is the intern health study, very similar to what I showed you about the rates of depression that go up in the beginning of intern year. This is actually data from average mood ratings in 2018 and really 2018, 2019, the year before COVID, and these are the ratings during COVID. And you can see a big dip in interns' daily mood during the start of COVID-19 compared to the year before. These are our trainees who are not doing well. And we at Columbia, and I will tell you a little bit more about CopeColumbia in a few minutes, but we also are trying to study what the longitudinal impact is on COVID and non-COVID stressors, mental health symptoms, and what are our sources of resilience and sources of support and the Columbia climate, and how does that protect or make us vulnerable. This is very, very, very preliminary data. I caution you to use it, to see it with it's very, very preliminary, but the take-home message is that our healthcare workers, and I'm focusing here actually on our trajectory of our physician trainees, medical students, residents, and our faculty, they all are reporting depression, anxiety, PTSD. This was a survey done September to December, so it counts as PTSD now, and burnout. And what you can see is that the rates are higher, although actually compared to the earlier studies, the rates are not quite as high as were reported during the peak surge. But what you can see here is that the residents, our trainees, are more severely affected compared to the attendings. And that may be because the residents are in the midst of developing their resiliency skills, their coping skills as to how to deal with the death and the dying and the severely ill. I can tell you that there was a very strong relationship using the Connor-Davidson resilience scale, and the higher the resilience scores, the lower the depression or anxiety or PTSD scores. So what can we do? How do we promote resilience? So let me tell you a little bit about CopeColumbia. CopeColumbia, we kicked into gear early March because we knew what was about to come down on all of our healthcare workers. And so we offered in a peer support model. Our goal was to offer our healthcare workers a safe space to discuss what they were going through and to enhance their own coping skills and harness the power of the group to build and enhance their resilience and allow them to keep doing the work that they needed to do. And we offered that in group format, 30-minute virtual groups that were facilitated by a psychiatrist and a psychologist. We offered it in one-to-one peer support, 20-minute phone calls available to people to support them. We offered it in town halls, in webinars, in grand rounds, in talks like this. And because of the information overload, we created a website so that we could have a central address for resources and information to help people navigate the COVID-19 crisis. And as you can see, we were very busy and we hope very, very productive. We had over 501 sessions and we reached almost 5,000 people through these efforts, and these efforts are ongoing. So let's just take a quick pause. Think about or put in the chat, what is your go-to stress reliever during COVID-19? Is it different from what your pre-COVID-19 stress reliever was? What invites positive emotions or relief from difficult emotions to you now?
Okay.
Do you want me to finish? I have a few more minutes if I could have just a few more minutes.
I think it's okay. Like 5 more minutes?
Yeah, that'd be great.
That should be okay.
Okay, let me tell you, because I think this is where we might stimulate some discussion. This is what we heard in our groups. These are the themes that emerged that our healthcare workers were grappling with: fear, anxiety, and uncertainty. These are the negative emotions they were feeling, the stress, the guilt at not always being on the front lines, the helplessness, the horror of so much death and so many bodies. There was anger at not being able to deliver the care at the level at which they were used to and the level at which they wanted to. There was numbness, there was disconnection, there was isolation, there was difficulty connecting to people outside the hospital because it was so difficult to describe, because it was so unusual what they were experiencing. And there was the distress of witnessing patients suffering alone. Residents, nurses, doctors were holding iPads, being the only connection between a dying loved one and their family. And usually where doctors leave the room to allow the family those intimate moments, the doctor was now the conduit and was present for this very intimate moment, which was at both overwhelming and distressing, and yet also described as incredibly meaningful. And there were silver linings and positive emotions that they experienced as well. They felt like they were bringing humanism into an inhumane situation. There was teamwork. There was a sense of camaraderie, a sense of shared mission, that what they were doing was important. We helped them connect and reconnect with their values, figure out what you care about, and then care about it. And COVID-19 also, we started talking about how physicians won't acknowledge vulnerability. COVID-19 leveled the playing field. It gave everyone permission to be vulnerable with colleagues in a way that is usually not okay and not encouraged. We had to ask for help as to how to deal with this, because otherwise we would have been lost. And we needed to find ways to take care of ourselves when we felt like we had no time. And it inspired gratitude from our colleagues who stepped up as ways to reinforce and appreciate and acknowledge all of what was going on. And my fantastic colleague, Anna Allman, a psychologist who works with us at CopeColumbia, created this amazing graphic that we call the growing resilience tree. It is ways to show that resilience can be enhanced, resilience can be grown, and these are evidence-based elements that are part of resilience. And so cultivating gratitude, again, let's take a moment in the chat, if you will. What do you appreciate about how you or your group has handled the challenges of the past year? Think of a statement of appreciation or gratitude, and please put it in the chat. I am grateful to all my colleagues. This is my group at CopeColumbia, led by Lou Baptista, Claude Mellons, and myself. To all the volunteers who stepped up to run these groups, who stepped up to answer the phones, who took on those people that needed more focused treatment, to Claire and to Maya, who I could not have done this without, to Dr. Lieberman, who provided some financial support for the research, and also as a leader, support for all of this work. As you think about what you're grateful for, let me just quickly summarize. Our frontline providers may have been the most intensely impacted by this crisis, but the entire workforce and all of us have experienced anxiety, stress, loss, grief, as well as trauma. But in spite of these challenges, we heard stories that are inspiring, that show resilience, that show commitment. And our workforce will likely thrive with proper support. We have to pay attention, but we can do it. And we need to facilitate treatment for those who need treatment. And we need to continue to promote that message that emotional health should have the same priority as physical health. And I want to just leave you with a short poem that I think captures the attitude that we have and that will keep us going. We are showing up imperfectly, but we are showing up. We are feeling ineffective, but we are learning and trying. We are insecure and uncertain, but we care deeply. My hope for all of you this weekend is that you rest and feel how deeply you matter. Thank you. Thank you for your time.
Thank you. Thank you. I know there are questions and comments. I just want to make one. I'm actually very moved by that ending. So, and as my colleagues know, I'm very emotional, so don't take it too seriously. But I wanted to say just a couple of things. One comment about the greater stress on the trainees than the attendings, that the role of knowing that the knowledge you have is not sufficient sometimes is stabilizing. Attendings know they know a lot, but they're facing something they don't understand. Whereas trainees feel like they don't know what they know. They don't know what they're supposed to know. They don't know why they don't know it. And I think that resonates very much with something we deal with in trauma across the board, which is the feeling of not knowing. That in itself is an enormous stress, the not knowing piece of it. So that's a very interesting piece of information. I think we have time, like, for, are there questions written into the chat box? Is anyone tracking
Well,
that?
I was tracking that. So
Okay.
we did not have any, well, we have one question, but we had some comments if you'd like for me to just blur out a few of those.
Sure, sure.
So Dr. Mayer, thank you so much for that wonderful and necessary presentation. And participants were really contributing their ideas as you were asking them to just kind of see what they do for their relief. And so that was a very active chat to kind of have to go through. And but there was a couple, comments throughout the presentation. Ariel said, "I'm thinking about the stress also causing less physical resistance and so more illness." Kevin stated loss of self-soothing and care from socializing with loved ones and peers. And Kristen stated that the frontline staff feeling pressure to work on site and feeling expendable, causing anxiety and anger, while also having the cognitive dissonance of fear for their clients whom they can no longer see. And finally, Janice asked, as well as I think everybody on this chat, can we get a hold of the PowerPoint presentation for future reflection?
I am appreciative, actually, of the engagement of this wonderful group in the chat, with your comments, with your suggestions, with your sharing of how you coped with it. And, I'm sure that for those grieving the losses, that's a whole other talk about how how we do that, as well as continuing to find that optimism to go on. And if you would like my slides, I am happy to share. I'm glad.
I see there's a comment from Irit that maybe you want to speak about it. It speaks to, your comment that caring for the caregivers, and it feels, I can't see because I don't have everybody on the screen right now, but I'm wondering if Irit would like to speak about that comment. Maybe not. Let me read it then.
Irit, you're muted.
I'm muting. Sorry. You know that
Okay.
this was the most amazing Christmas decoration this year, was a thing that says you're muted. Thank you very much, Dr. Mayer. This was truly an excellent presentation. And, from my perspective, as a psychologist who's very steeped in trauma work and in recent years doing a lot of trainings for physicians and healthcare providers about caring for trauma survivors when they are patients, people who had trauma in prior times in life and now are patients. I think that one of the silver linings, one of the good things that might come out of this is that very amazing thing that you pointed to, that it allowed healthcare providers, all of them, to be vulnerable. It highlighted the incredible urgency as a society to provide care for those who care for us. So from both sides, it highlighted the need for such resources and for that attention, and it legitimizes, hopefully, for physicians and nurses and all of those stoic, helpers, that they sometimes also need to ask for help and to accept help. Because otherwise, what often happens, and I think you spoke to that in one of your slides, you know, not only patient satisfaction goes down, but there are some pretty chilling empirical findings about how burnout and all of those other things you talked about lead actually to dehumanization on the part of the healthcare provider towards patients.
Your comments are spot on. And if you got that from my talk, I feel good. And I think that we do have an opportunity to really rethink and change the culture of medicine to one that is more compassionate, high achieving, excellent care, but one that is more compassionate of us as people and as humans, doing the best we can in the circumstances that we have, and knowing that our circumstances and the context will always change. And sort of how we feel right now is not the way we will feel forever. And to keep those silver linings, to keep the optimism and keep those things that ground us so that we can keep moving forward. I completely agree with you.
Thank you.
Okay, so, you know, I'm going to introduce, thank you. I'm going to introduce the last speaker, and I think there will be time at the end if there is a wish to have a discussion with everybody. If there are a lot of people still in the meeting, I think it's best to still do it through the chat box. If the meeting gets a little smaller, maybe we can just have an open discussion. I know that Shanae had to leave, so maybe Siva can, or Elaine, you can help coordinate that. So our final speaker is Amie Leigh, who is the Director of Public Health Initiatives for the SE Trauma Institute, which was founded by Dr. Peter Levine. I know many people attending this meeting are familiar with the Institute, and many are actually trained in somatic experiencing. But for those who are not familiar with it, the SE Training Institute trains mental health and wellness practitioners using the neurobiological intervention of somatic experiencing, which supports resolving trauma through work with the nervous system. Amie's work deals with public advocacy and program development, creating resources for dealing with community-wide crises, including disaster and social unrest. Presenting on behalf of the SE Trauma Institute about this program, she will briefly demonstrate a practical and tactical means for altering the potential impact and long-term effects of traumatic catastrophic events using SCOPE, S-C-O-P-E, a tool from the Crisis Stabilization and Safety Toolkit. Amie?
Thank you so much for that introduction, Karen, and to the previous speakers. My goodness, it is so powerful. It is just so powerful to be here with you all right now. And I don't want to miss letting that experience of connection go by. I mean, we just heard these really phenomenal presentations. There's a way we're intellectually stimulated, we're passionately stimulated, our hearts are moved, we've had poetry, we've shared life experiences, and I really just want to introduce myself to you by introducing you to everyone else on the screen. If for just a moment you could really indulge, if you're in gallery view, which I think we're on meeting and you can be, here's a new innovation fun thing about Zoom. And thank you, Dr. Mayer, for asking us to find what was really exciting about this moment. I realized it was innovating new ways to be together. We are globally together, and I'm looking at each of your faces, wishing I could see you in the room, and I invite you to look at each other's faces. When you are experiencing the sense that I am alone fighting in an urgent reactive scenario, there is so much pressure on me, recall just the resource of this group, right now is here because they care like you do. Like you have an infinite amount of resources right now. And that's what I'm just blown away. Thank you for letting me be a part of this. I'm practically moved to tears, but I'm trying to just hold it so I can be with you all. It's just extraordinary how much you each are caring for your own communities. And I can, Dr. Abel, is it Learwellie? I'm not sure I'm going to say that right. And I'm sorry if I said that wrong. But just to be with this invitation for resilience in Liberia. We could be with all the catastrophes he was describing. He invited us to be with him. But really, he adamantly invited us to be with how resilient the people are in the face of these calamity experiences. And Dr. Mayer invited us to be with this arc of the disaster phases, with this sense of bewilderment and wonder of what happens now? We're all in that together, but the magical piece there is together. So I say that because I'm going to prime you for us to do some experiences together. So I need us to really be together. So that said, I'm going to put up some little slides, and so that but I still would like for you to all see each other if you can. So if you have a line in the middle of your computer screen that you can, sometimes there's a little dash in the middle and you can move it over to the left so you can see more of the people present, go ahead and do it. So you see these slides, but I really want you to keep seeing each other. Really keep seeing each other and be nourished by each other's faces. I don't see any masks on anybody, and we're all pretty darn close. I think we're less than an inch away on the screen, but really let yourself be resourced by it. It's a fundamental human need. So from the SC Trauma Institute, I'm also here with my colleague, Ana Paula Bastian, who is our Director of International Relations, where we train people in neuropsychological ways to resolve trauma, in over 36 countries at this point in history. Tens of thousands of therapists, coaches, and related practitioners, including medical and emergency responders, have been trained. I know many of you are, and I'm really excited that some SE community is here with us. Let's see if I can move through these. I'm just really here to really briefly share with you that we are at a new time in history. I think many of us are experiencing this directly ourselves, if not through our practice, which is that we're at a point where it's going to be very difficult to talk about psychology, trauma, or resilience without talking about the nervous system. We're learning so much that the fight and flight responses, the freeze and helplessness, all occur in our body in such a profound way. And there's a lot of ways we could look to begin resolving them. I'm not here to teach you SE today. I'm not SE faculty. I'm not going to talk to you about resolving lifelong trauma, but just asking you to consider that the nervous system is an extraordinary tool for resilience. And we can see in this window of tolerance, which I love to call the range of resilience, cited to Dr. Dan Siegel, is that when we have a traumatic event, our nervous system responds sometimes by getting stuck on high or stuck on low. We're outside of the range of what's comfortable for us, our resiliency zone. And what happens there is we may find ourselves in a state of panic, urgency, worry, extraordinary pressure, maybe just irritability with all humans. Anybody else have that? Or a sense of, I'm so stuck, I'm so flattened, I can't get off the couch, I can't get myself activated. That's what we might call stuck on low. And so what we are doing at the Institute right now is we started responding at the beginning of COVID by assembling teams of somatic experiencing practitioners, neuroscientists, researchers to really boil down some of the real complex nuances of somatic experiencing to make an adaptable and accessible toolkit that could be like a rapid response, rapid resilience access. And so what you're seeing on your screen right now is one of the tools from the Crisis Stabilization and Safety Toolkit. I would invite us all, if you'd be willing, to go through this tool with me. And so we've been sitting for a while, and you may or may not want to stand up, and it may seem odd or weird or embarrassing, but I really invite you to consider that. I'll go ahead and do it. Welcome to my home office, everyone. Here we are together in each other's lives, resourcing each other, resourcing each other, resourcing each other. If we do these kinds of exercises in periods of low or no stress, when we have a really high level of activation, this quick little 5 set of exercises can really bring a reset quite quickly. It borrows from SE, from polyvagal theory, many of the things y'all are aware of. Okay, so can you still hear me if I stand up over here? Okay, good.
Yes.
All right, so I'm going to go through it together and model for you why. Well, and considering this was made for emergency responders, so it was designed for even an intensive care nurse to be able to do while walking down the corridor from one room to another. You know, not having time to stop and slow down, not resolving all the trauma and crisis, but getting more access to that stable center. So the first one, the S is for slow down. I actually really wish we had called it slow stepping to be more precise. But I have that little tiger there because it's slow stepping, putting all of your attention, I'll move the computer even on, all of your attention on your feet. I really right now am noticing the ball of the heel of my foot, the ball of my foot, the heel, the ball, and you walk artificially slow. Now, if no one's around, I always say creep like a tiger. 5 to 10 steps with your mental acuity on the soles of your feet. Connect the nerve that runs from the bottom of your heel to the base of your iliac crest, up all of your paraspinal nuances into your subcranial responses, your cranial nerves, and it begins to send a signal to the entire body. It's okay to reset. I can reset. Really, I get more feedback about this little part of the exercise than any of them. I also put the tiger in there because Dr. Peter Levine's book, if anyone wants to look for it, Waking the Tiger, transformed my life, and it might transform yours. Okay, the next exercise, you can do standing or sitting. You can do it when no one knows you're doing it, which is why it's lovely. It's creating a closed body loop. So you take your hands and you can place both under your armpits, or you can put under one and on the outside of another arm, whatever comes sort of naturally for you. And then cross your ankles. Sometimes I even add a little compression, like a little intentional compression, and lower your head for just a moment, which creates a closed body loop. You know, children do this automatically. It's known to us. I'm just going to close down for a minute. I'm going to pull all of that energy that's out back into my center so I can re-embody my own person, reintroduce some choice from the center of my being. You might notice as you do any of these, I'm going through them quickly in the interest of time, but you might notice a heave of a sigh or a deep breath. That's a signal from your nervous system. It's doing some resetting. I think if it hasn't happened for you yet, it will happen in this next one. We're going to orient next. Orient, we'll just orient using your eyes. You could orient using any of your senses, but we'll orient using the eyes. I invite you to look away from the screen and all these magnificent faces who are with us and look around the space that you're in. You could do this a couple of ways. You could move your head and your neck and follow the lines of your room. You could look for colors and inside your own mind name them. I see red, green, cream, yellow, blue. That just begins to orient you to precisely where you are in the universe. Which, by the way, when you're feeling extraordinarily threatened, your eyes zero in like we do on Zoom, and you can't get spaciousness, you can't get capacity. By orienting to looking far away or at something you find pleasant or pleasing, your nervous system settles. It comes a little bit out of fight or flight or freeze. So again, you might have noticed a breath. I might be doing these too quickly for you to get that, but you can try it later, I promise. And then pendulate. Now this is a sort of abbreviation of a much deeper principle in somatic experiencing, but for a moment, put your attention in your body, this is for the P, pendulate, on a place where you might have a little bit of tension at the moment. Maybe it's in your lower back or stomach, maybe your chest, or maybe you have that crink in the neck from the computer. And just notice that tension a little bit, and then move your attention to somewhere where there's softness or spaciousness. I have a little tension in my diaphragm. And I have spaciousness on the sides of my arms. As you notice that, move your attention slowly back and forth from one to the other. And when you're with the tension, then go to the place of ease, then to the tension, and the place of ease. There is no goal. We're not trying to resolve the tension. But those of you who've experienced disasters, or that phases of disaster chart we just saw, you know that moment of helplessness is when you had no choice. This pendulate that we do here is nice because you have the choice of where you put your attention, and no one can take that away from you. And so really, as you begin to experience the power and the resilience of choice, you may experience some expanding capacity. The last one is engage. Engage can mean a lot of things, but specifically here, we've connected here with the importance of social engagement. Whether we're introverted or extroverted, connecting to other humans is essential for human survival. And I think even when we heard about Ebola and having, not wanting neighbors to knock on the door, I think we all know that feeling right now around the globe. Come close, don't come close. We still need some form of engagement. If you're a little more introverted, you have that one person you like to talk to who's maybe a little bit more in depth. Reach out to them. Share this resource with them. Maybe this would be interesting and a good excuse. And if you're more extroverted, please share with everybody. I think this is the beginning of a program that I'm hoping really enhances a lot of folks. We've gotten feedback from politicians, first responders, public safety officers, nurses, medics, academics, that this has been, journalists, that this has been helpful to them. And so it's very simple. And by the way, we talk about frontline workers and essential workers and emergency responders. And the truth is, we're all emergency responders now, aren't we? We're all in an emergency and we know it. So stabilizing ourselves can really help us to maintain. This website you see on the screen now, traumahealing.org/scope, has an 8.5 by 11 printout of that scope picture I just showed you. You could print it out wherever you are. If you remember, S for slow stepping, C for closed loop connection, O for orient, P for pendulate back and forth, and E for engage. You already have one more set of tools in your toolkit. You could also scan this little QR code if you're into tech fun stuff like that with your photo app on your phone, and it will also take you there. So thank you for letting me share that with you, and I'll keep you abreast of it as the program develops more. And I really rest in this place where we are embodied in our resilience together. And my embodiment is every one of you, not just this body. That's really significant and what's getting me through COVID. So thank you.
Thank you. Thank you.
Thank you so much.
Let me see if there are any very specific, before we open it up for the general discussion, if there are any specific questions. I just want to say, I took up my phone to take a picture of that code, but the phone immediately asked me if I wanted to go to it on its website. So
That's the idea.
for those of us, it's really very easy to get. But I'm just wondering if, I know that our intern had to leave, who was really monitoring this, whether there were any specific questions.
Well, yeah, maybe let me see if I could help.
No, there was no specific questions.
Pardon?
Because we're all so relaxed now.
Siva's also helping us.
Okay.
Let's just see what we have.
There was no specific question to this particular session, but there was one question which I have shared with the first speaker. So when we are opening up the general discussion, he will answer to that first question.
Right, yes. So let's see. I mean, a lot of people have said really positive things. I mean, about how helpful this is, how good it is, for self-care, and, that they're going to be trying it. There's a lot of, positive responses we've heard from people.
Yeah.
What did people have? There been differing responses? You said you've done this with EMT workers and frontline hospital workers, and have you noticed differences in the way people have used it or responded to it?
Absolutely. We're actually now developing out the program to be like a complement to psychological first aid and mental health first aid. There's going to be like a 6-hour and a 40-hour training. And we've realized from the feedback we're already getting that we can't dump it in one bucket. For example, an ICU nurse or medic of any kind may say, there's nothing pleasing in my environment to orient to. There's nothing I can look at. Those of you working with medical professionals know, like, I don't want to look at this. We can say, hey, get a watch band that has a smile face on it you like to look at. We can try and get them to. When I work in disasters, when I was in the Bahamas after Dorian, everybody was just looking at bodies and buildings in little bits. How do you find something pleasing there? And often we have to invite people in different professions to go to a different place in their imagination, perhaps, and wait until we get the physiological signs that they've actually arrived there. Right. Same with law enforcement. So this was more fun with law enforcement, honestly, because I thought they were going to throw me out of the room and they didn't. They actually took this very seriously because they were willing to recognize that they were nervous systems interacting with other nervous systems more than psychology interacting with other psychology. That was really accessible. So I was very surprised to get great feedback from law enforcement that this was worthwhile for their own fight and flight responses. So, but we're finding they really need to be adapted for different audiences. And that's what we're working on now. In fact, I invite any of you to connect with me. I'd love to work with any of you. Developing this, so it's more acutely adaptable for the populations you all serve. I mean, that's, there's no doing this. We just need this out there, don't we? We need more resources.
Right. And I think a really helpful thing, I mean, everyone's had like at least some positive experience in their life. So I think that's a very helpful thing to try to recollect that, especially now, when we work with people, or maybe we ourselves are struggling with everything seems so bleak and depressing. But, we've had, like a vacation or, a great moment, in our past to kind of, think about that, because that's very helpful.
Hi, Amie. There is a question from Ariel on the chat box. And if you'd like to respond to that, that'd be great.
Absolutely. So thank you. And to Elaine and Ariel, so to Elaine, scope is just one tool. You can't do everything with a screwdriver. You need hammers, you need drills, you need other tools. Right. Scope is just one tool in the toolbox. We have a whole tool that's about reconnecting to positive experiences, because that's huge. And to Ariel, yes. So the SE Trauma Institute, I won't make this a commercial, although I'd love to get you all enrolled. We've been educating people. Well, Dr. Peter Levine founded it quite some time ago and has been educating primarily therapists, coaches, and anybody who works with one-on-one trauma responses in people around the world since I think the early 80s. Internationally, what the Institute does is we offer trainings in all different regions around the world. It's a 3-year training program, 4-day weekends a year to get your continuing education units, to get whatever certifications you need in your own region to support your licenses. I know that's very different around the globe, so forgive me if I fumble that a little bit. But everybody can go through the training and become a certified SE practitioner, which is like becoming certified in EMDR, any other modality that supports the work you do. That's what we do internationally. We're also right now creating a panel to respond to the earthquake in Croatia, where we'll have our faculty as well as some of our disaster experienced SE practitioners, just providing some engagement support and resources to some of the responders there. We did that after the Australia fires also. So when we tried to with Lebanon, we didn't do a great job with that. We're learning as we go, how do we continue to pivot and really be where humans are saying, come help us, right? You all know that. There's a sense of how far can our help go and what's realistic and how can it resource. So what we'd really like to do is just keep educating people around the world with these resources so they can adapt it for their own cultures and it can go farther and farther. Does that answer your question, Ariel? Sorry.
I don't know if she's on mute or not. I just wanted to add, since for this particular presentation has a lot of participants who are clinicians because of the nature of the topic. But I wanted to add to the members of the audience who are not clinicians and all the people working in other areas of healthcare administration and public health issues and global, community issues, that this tool is a useful tool in any context. I can see, forget, no catastrophe going on, just stress, and in the workplace stress. And you think about the little catastrophes in workplaces, the people who are the support behind the support behind the support. Very neglected layers of, even, whether you're talking about people working in warehouses, getting those boxes of masks shipped and delivered, to people working in administrations that are making policy decisions and trying to understand. I think policy decisions could be well informed by getting more connected with one's nervous system to begin with. So I just wanted to put in another perspective on that.
It's great that you said that. One of the people on our work group who you all would love so much, she just helped get some legislation through the House in the United States Congress to get mental health care to high crisis foreign service officers. And, here's a weird spin. I don't mean to disregard the grief, the loss of life, and the agony the world is experiencing at the moment. But for all of us in these professions, haven't we been finding, I feel like I've been doing jumping jacks in the disaster space saying, well, people see that mental health is as mission critical as fixing buildings. Like, can we understand how important psychosocial mental health community support is? And those of us been working in those spaces know how exasperating that is. But right now, for the first time, there is no one in the world who is not sitting up and taking notice when you say, we want to talk about good mental health, finally. So can we see this as just the most beautiful moment to transform the world through the things each one of you have been passionate about in social work, public health, and so united around it? Could this be the best moment in our human history? Could it?
Well,
again, no disrespect meant, though. I don't mean to be so optimistic that I'm.
No, but I think what you're referring to, and I don't know if anyone wants to discuss it further, it's, we talk about resilience, but what we haven't quite talked about is what a lot of people term sort of the wisdom of trauma, the way in which trauma grows our knowledge and can lead to a wisdom that we can't have without it, and as Abel said at the very beginning, there's always trauma, we're always stressed. Some places in the world suffer more than others. There's no question about these discrepancies, but it is about it's also about consciousness, right? The fact that we have to teach that mental health is an essential part of healthcare. I hope that young people coming up in the field, have this happen sooner than those of us who are older, where, there really has been a marginalization of mental health awareness. And I think tragedies and traumas like this are changing that. So we have a little time. We don't have to keep going if we've discussed it all thoroughly. I just wanted to just give people a last chance to, unmute yourself and ask something or say something.
I have something else I could say, but I want to hear from our attendees. Anyone have a comment or a question or anything in the chat? Yeah, well, I see crisis can lead to opportunities. And I think, we're all kind of familiar with the kind of, someone said in the chat, and, we're all very familiar with, the kind of the Chinese word for like crisis. One of them is opportunities. And I think this is what's happened. I wanted to just go back, and maybe this is a way of kind of uniting, our three presentations. Just in the kind of cultural and I guess professional differences to dealing with, with trauma, and, or even more important, resilience. And, and the whole issue of, I mean, I just think from presentation about Africa, people are very resilient. Can you imagine a civil war for 40 years and what, the impact of that? The two, not one, and we're still struggling with one pandemic, but two pandemics, and so it's so much, so much average, but people seem to have to cope with it and to be very resilient, right? And also, I mean, I think health workers, cope with it, very well. We heard from our, second presentation, and then that, but then just in terms of these methods, I think are, that Arnie, mentioned, I mean, I think are very, helpful in terms of dealing with it. And I know you've done work, like all over the world. And I wonder if you picked up some cultural differences, just in the way people deal with them. And I know you mentioned that somehow in Lebanon, it didn't quite work as well as you had hoped. And I just wondered, what was it, kind of what were some of the issues, or, if people, or some people are more amenable or more able to do this or than others.
Elaine, is that question to me?
Yeah, I guess so. Or I mean, anyone can participate.
I could open this to all of us for sure, but I can speak to a moment. We brought a team of therapists down to Freeport in Bahamas right after Hurricane Dorian. And the idea was to create a trauma relief team and explore new ways of working with their social workers. And what we found was our team was mixed with medics and psychologists. The psychologists came in, well, psychologists and people trained in the field of psychology, various counselors. And the counselor kind of came in the house. We went into one house that had about 15 people who were all family or neighbors connected, whose houses had been destroyed, and they were now all staying in this one home. And they were milling about very, uncomfortably. The psychologists were milling about uncomfortably in the crowd. They weren't in an office. They weren't asking the usual questions. There was no intake. They were not going to be able to see someone next week. That wasn't going to happen. And so I saw and was concerned that the therapists were going to be traumatized by the experience, because there was a sense with them of, oh, I'm a little bit uncertain of what to do here. And, we were trying to figure out how to get them into a space that they felt really proactive. At which point there was one nurse who formerly had been a professional dancer, a ballet dancer. And there was a young woman, a young girl, she was about 15 years old, sitting on the couch, staring straight ahead, quite comatose and in shock. And this nurse went, while the therapists were milling about, the nurse went, and, she was a white American suburban nurse. I'm just going to name that, in a brown-skinned culture in the Caribbean, different cultures, different worlds, bewilderment on all sides of what is it like to be you. I don't really know your experience, but human to human, I really care. And I don't know how to most respectfully cross this threshold right now. But the nurse did this funny thing. She sat down next to the teenager, and maybe it's because she was a teenager, it was easier. And she took out her cell phone and she pressed a song on her radio. And Karen, you said something about younger people and what they're doing these days. Well, she pressed a song on her phone, and it started to play some good beats. And at this point, the teenager, who had not moved for maybe an hour, turned and looked at her like she thought she was crazy. She thought, why are you doing this? Next thing you know, she bumps her hip. And within 5 minutes, the two of them, the nurse and the young girl, are bumping hips. They stand up and they start moving around. They start choreographing a dance together. The teenager starts laughing. The entire house ends up out in the yard dancing for the rest of the afternoon. Well, they are in unspeakable grief. And so for those people who work in dance therapy or for any kind of physical yoga, any modalities that are physical, there's something so universal about meeting in the body. But how do we get there? It's very awkward if we're more comfortable living right here. It's just awkward. And so as we get through that together and resource each other, I've worked in many cultures and I've bumbled my way through. I've been given an enormous amount of opportunity to reach people who've let me into their worlds or let our teams into their worlds. And so I always err on the side of a brave risk and courageous vulnerability and bring as much humility. But that's this one. And I know you all have done that too. So please don't let me overspeak. I'd love to hear. I know, Dr. Mayer, when I saw your presentation, I realized, oh my goodness, we've been working in some very common spaces. I'm really, really excited by what you've been doing. And I'm so excited by what I heard in Liberia. And I imagine each one of you has a world of responses you've done and places you've braved through, reaching outside your comfort zone. Because working in crisis is different than working in lifelong trauma.
I would like to respond to that a little bit and say that I think what you talked about resonates very much with what, to me at least, with the importance of actually preparing mental health and crisis workers of all disciplines better for what they're about to do. Because I will, as a psychologist and as someone who comes and who grew up her entire life, as I say, I come from Israel. And I always say that my training in trauma preceded by many, many years my training as a psychologist. So I think that, but still as a psychologist, I will say we're not all just here, especially not as trauma specialists. And that actually highlights the need to not only take care of trauma specialists and medical professionals and psychologists when they're already exposed to trauma, but how important it is to prepare people appropriately for trauma, and that it is not the same to be out in the field taking care of people in crisis as it is sitting comfortably in an office and talking about how offended you were by this or that or whatever. Yes, it's different. And it's again the same issue of tremendous trauma. You know, when I came to this country and I was asked, what do I want to put on my card? I was already a trauma specialist, but I chose not to put it on my professional card because it was so kind of out of context and irrelevant here. But now, as a culture, we are here too, faced with tremendous traumatic events, the military conflicts of the recent years, the political issues, the pandemic now. And yeah, we have to prepare young professionals to deal with this differently.
Thank you.
And it seems to me that this again takes us back to a cultural change, not just in medicine in general, although that's very important, about
Right.
trauma, about the neurobiology and the unspeakable nature of the experience, particularly immediately, but not. I work long term with people, and so to train a larger, broad spectrum of healthcare workers, one, about trauma, but also that's why ISSTD trainings are so important, because we don't get that in our graduate educations as mental health workers, not in this country, certainly. And Israel in the streets of your lives as well, and you almost can't dissociate it. But we continue to dissociate it here in America, that in the impact of violence and loss and overwhelming grief and terror impacts us. So we have trendy diagnoses to focus on symptoms, and it really has to be a culture of education in a real broad spectrum way, I think.
You know, I just want to, before we run out of time, just segue into a little bit of an announcement that for those of you who are attending this, who have not previously come to a meeting like this, that the trauma working group, which is one of the working groups of the NGO Committee on Mental Health, is a growing working group. It's interesting in the last couple of years, the membership of this working group has grown steadily. There are many people who want to get more involved in these kinds of both educational and administrative and learning experiences, as well as, involvement in the United Nations. It's for many of you who are involved in the United Nations, you know what an endeavor that is. So I wanted to just say that Dr. Irit and I are going to hold a meeting possibly next week. I mean, this would be short notice for some people, but I can send out the information for anyone who would like to join the trauma working group to begin to talk about what else can we do, not just once a year to have a meeting, but how are we going to educate particularly the UN community and the NGO community at the UN that, I always say the first thing is they talk about healthcare, we have to talk about mental health care. They talk about mental health care, we have to talk about trauma-informed mental health care. When people ask me, what do I do at the UN? I say, that's all I do. I just raise my hand and say trauma-informed mental health care. So if anyone is interested, you can reach me through the website. My email is linked to the website. I don't think yours is, Irit, but if you want it to be, we can do it. And express your interest, and I will send you the information about the meeting we're going to have to try to brainstorm various different things that we could do, writing white papers, connecting with, missions, bringing people together, maybe teaching a little SE to some of the, so let us know if you're interested.
Any doorknob communication? Yeah, as we, it's near the end of the program.
I think so.
Well, I think I just wanted to say this year, Karen, you organized the program, and I wanted to really congratulate you and say how wonderful it was. I think we had an amazing program today, and to point out that indeed, I think as Amie said, the fact that we can't be in the same room is a great loss, but we also did have this wonderful opportunity to have such a bigger audience because of that. And that's really wonderful. So thank you very much to you and to everybody who helped organize it this year. It was really fantastic.
Okay, right. Everybody breathe.
Thank you so much. I learned a lot today.
Thank you.
Thank you. Thank you.
Thank you.
Thank you so much.
Bye.
Thank you.
Thank you.